Okay, I'll just start sharing. Just 1 second. Go back. Okay, so hi everyone. Welcome to the SBAs in acute and chronic pancreatitis. As Yezin has introduced me, I'm Santhosh. I'm a sort of clinical educator with a background as a doctor. So I'm currently working for a university. So today's session, we're sort of going to be going through the etiology, epidemiology, presentation, management of both acute and chronic pancreatitis. So we're going to be looking at both of them really. And then we'll also kind of look at prognosis and complications. And the way we're going to be doing this is linking them to SBAs that you guys will be able to kind of answer. Okay. So without further ado, if we start with our first question, okay, so Millie will be able to put this in a poll. So please all answer, please attempt it. If you don't know the answer, it's absolutely fine. We will be kind of going through it all in a second, okay? Okay, so the poll should be up. Like I said, please all answer it as soon as you feel ready. Please just have a go. If you don't know the answer, it's absolutely fine. Okay, brilliant. So most people have put B, okay, which is the correct answer. So I'm just going to close this, okay. So yeah, just to kind of sum up, we will be talking a bit more detail as we kind of go on. But so 38-year-old woman, she's coming to emergency department, so we assume this is more of an acute thing, really. And she describes it as a constant pain, but it is worse when she moves, and she has vomited several times. Okay, her bowels are normal. We've got a lot of information there. Okay, and that's already given us sort of what it could be, but also it's really important to rule out what it's unlikely to be. Okay, so we've got things that are sort of pointing away from stuff and things that are pointing towards acute pancreatitis, which we will talk about when we talk about acute pancreatitis. Okay, so well done for people who, well, everyone who actually voted who got that correct. Okay, so the second question. So a 50-year-old woman now is admitted with an episode of suspected acute pancreatitis now under the surgical team after presenting with upper abdominal pain. So it could be the same lady, but you know it's not because of the age. They're waiting for the blood results to come back. So which of the following single blood markers would be the most helpful in confirming her suspected diagnosis? Okay, so I'll let you read the answers, and I'm sure Millie will put the poll up. There we go, the poll's up. Again, please just guess or make a kind of estimate or guesstimate if you don't know exactly.
5 seconds.
Okay, guys. Yeah, well done again. Okay, so again, we will go through this, but well done everyone who put an answer, everyone was correct. For those who didn't put an answer, that's absolutely fine if you don't know, but it is good practice to sort of just try and guess, guess or make a kind of assumed estimate. Okay. Another question now. We've got a 45-year-old female who's present with severe epigastric pain radiating to the back. She has been referred, or she's been under the alcoholic detoxification team, but she's not actually attended really yet. She's got a positive Cullen sign and she's hypotensive. So what is the most likely diagnosis? I'm hoping this one might be slightly more obvious.
Another 5 seconds.
Okay, good. So thank you for those who didn't know, maybe answered it. It's really good because it gives me an idea of what people are thinking so that we can spend a bit of time going into it. Okay, so the correct answer was acute pancreatitis. Now, don't just think, just because it's a acute pancreatitis lecture that all of the answers are going to be that, because we can sometimes put some other things in just to sort of, see. So some of you put perforation. Some of you put duodenal ulcers, but acute pancreatitis is the correct answer. Okay, so we will sort of go through this very quickly. Okay, the big risk factor here that is kind of hinted at here is that she's a known alcoholic. Okay, and as we'll talk about, that's a huge risk factor for acute pancreatitis over A and B. It is a risk factor for a variceal bleed as well, however. But A and B, it's not usually a sort of risk factor. You can have people who have perforations who are alcoholics, that's fine. But the link and the kind of risk is more towards the acute pancreatitis, okay? The presentation here is classic for acute pancreatitis. We've got this pain radiating to the back associated with nausea and a positive Cullen sign, which is actually quite rare in reality, but when it's present, it does point towards C over the other presentations. Okay, so we're going to be going over this now. All right. So acute pancreatitis is the inflammation, as the itis suggests, of the pancreas. And usually you get destruction of the pancreas as well. It's a really, really sensitive and quite a fragile organ. So prolonged inflammation or really severe inflammation can lead to destruction very quickly. And because of that, it's a really nasty disease. It's a nasty condition with a high mortality. And unfortunately, we are seeing more of this in the UK. And that's mainly because of alcohol. So when we look at the causes, a lot of people associate it with alcohol, and it is a big risk factor that we've talked about. However, it's still within the UK, not the number one cause. The number one cause is still gallstones. But what we're seeing here is that is increasing, hence why the overall incidence is also increasing. Okay, so these are the two biggest causes. There are lots of other causes as well. So malignancy, particularly head of the pancreas tumors, can cause kind of acute pancreatitis. Hypercalcemia from any of the causes can lead to it. After ERCP is a common kind of presentation. And if in your exam question it has that, so someone who's just had an ERCP, again, you've got to be kind of thinking that really it's you're basically putting a tool inside and looking around with it, so it's not going to be happy. It's going to cause a bit of inflammation around where you put the camera. Okay, trauma is quite rare, and infections, again, it relatively rare, and some drugs it can cause it, but again, it's quite rare. Okay, so we're looking mainly at those top two, and then potentially this sort of middle section. Okay, so we talked about that classic presentation, and this is it really. So epigastric pain, radiating to the back, which is worse with movement. Okay, there can be guarding. So sometimes you can have patients who sort of have that peritonitic look where they're sort of just in the bed completely still and they don't move, compared to maybe a kidney stone picture where you've got that classic writhing around in the bed, can't get comfortable, can't keep still. Okay, so it's the opposite of that. All right. The radiation to the back is quite useful in kind of pointing towards the acute pancreatitis, but in certain scenarios, it can occur in other things such as perforated ulcers and things like that. But if you do see that in an exam question or anything like that, it is classically related to acute pancreatitis. All right. The pain tends to be constant rather than a colicky pain that you would get with sort of gallstones or anything else, really, obstructions, that kind of stuff. It is that constant pain, but then is just aggravated with any movement and sort of really, really hurts with any movement. Okay, you will almost always get nausea and vomiting, and now that's a mixture of because the pain is so bad, and also because of the actual acute pancreatitis itself. All right. It's important to realize these patients are unwell. You won't get a patient with acute pancreatitis who has a bit of a niggly pain and is walking around, especially if it's moderate to severe, they will be unwell. Okay, so we're talking deteriorating observations, they look unwell, and they have a lot of pain. Okay, very rarely it can cause jaundice, particularly if it's caused by gallstones. So you can get obstructive jaundice because of that. And we talked about these two things. So Cullen sign and Gray Turner sign. So Cullen sign we already mentioned, which is this periumbilical bruising here, and Gray Turner's, which is kind of bruising more to the side. And this is quite rare. But it's actually associated with really, really severe pancreatitis that has actually started to lead to a bit of necrosis and therefore some bleeding, a hemorrhage as well. Okay. Good. So once you've kind of thought, you've done your history, you've done your examinations, and you're thinking this could be acute pancreatitis, you're then going to do some bloods, I would hope. And so the big one you're going to do here, along with all of the routine stuff, is the serum amylase. And that's the one that really, really aids diagnosis. Okay, so full blood count, CRP, renal and liver are all really important. But amylase is going to be the one that is going to separate this from other things that present in a similar way. All right. And the serum amylase is going to be really, really high, not just slightly elevated. It's going to be very high. Okay. Lipase is used in certain hospitals, but in my experience, amylase is more widely kind of used, I think, for cost. So don't worry too much about that. And once you've kind of suspected this, you then want to go and have a look at an ultrasound, mainly to rule out gallstones as a cause, because like we talked about, it is the most common. So if they don't have any gallstones in, your next kind of thing based on the history would be, is it alcoholic induced? And if not, then it would be, it could be one of the sort of lower down on the list. Okay, but an ultrasound would guide us as looking at the cause really. All right. CT isn't really used to confirm in ordinary cases, but if you're kind of unsure of the diagnosis, you're not convinced about the bloods or the ultrasound, then it can be used to kind of look at the pancreas, although it doesn't usually give us a great picture. Okay, so the main things that we use are the clinical history examination and the amylase with an ultrasound. Okay, so we're going to talk about the pancreatitis score, which is basically used to predict the likelihood of severe pancreatitis. Okay, and this is really a classic exam question. So please try as much as you can to to sort of remember this. They love this really. In reality, we have kind of performers that will help us with this. So I'm not going to go into a lot of detail, but the main thing is age. Yes, it's going to be a risk factor for severe pancreatitis. The older you are, the more affected by pancreatitis you're going to be, and unfortunately, the worse prognosis it's going to be. Albumin. So if you've got low albumin, it often indicates kind of a worse degree of disease. If you do a ABG and you've got a low PO2, again, it sort of shows progressed disease because you'll have an element of respiratory failure. If you've got a low calcium as well, that can indicate that things aren't going in the right direction or it's a lot more severe than normal. High glucose and high LDH as well is part of the scoring system. Serum urea, again, is used there, and the white cells are used to kind of show the sort of the inflammation point, really. Okay, so if you have a score that's above 2, it's basically showing more severe pancreatitis. So it's not used to diagnose pancreatitis. It's more when you've actually diagnosed it, it's kind of a way of scoring how bad it is, because it can vary a bit. All right. Okay, so a 50-year-old alcoholic is diagnosed with acute pancreatitis, and she presents with abdominal pain. She's awaiting to be seen by the surgeons, but becomes really unwell within the department. And we've got here her observations don't look great. She's tachycardic, she's hypotensive, with a slightly high respiratory rate as well. Okay, so what is the most appropriate initial management of treatment? And bearing in mind that I've stressed that word initial management. Okay, so Millie will put the polls up, and again, please just go for it if you don't know exactly the answer.
Another 5 seconds.
Okay, good. Right. So most of you put E, which was the correct answer. I think 2 of you put C. So again, remember that I stressed that kind of that word initial management, because you're very right. I mean, you could need to use all of them, maybe not A, but this lady might need all 4 of these things, but there's often an order that's important. Okay, especially with unwell patients in A&E, we've got to think about order and priority rather than just sort of giving treatment. So the key here is what's really alarming is this blood pressure, okay, and the heart rate. So she's clearly quite unwell, but she's also hypovolemic, and that's common in any unwell patient, but it's common in acute pancreatitis as well. And if we don't correct that, then she could go into circulatory failure relatively quickly. Okay, so we really need to correct that, and the best way of doing that with at the current kind of situation is to give her some IV fluid resus. Okay, so basically trying to get that blood pressure up, and then we can think about everything else that we want to do. Okay, so it's really basic things. Really, it's not anything that's specific to acute pancreatitis. It's just highlighting that these patients can become really unwell very quickly as well, because remember, she's been in the department and then she suddenly deteriorates. Okay, good. So now we've got a 50-year-old with a medical history of obesity, constant severe upper epigastric pain. She's got a diagnosis of acute pancreatitis, and she says she had a procedure to investigate, a stricture basically. She's otherwise well, doesn't have any other kind of risk factors. So what do you think is the most likely cause of her acute pancreatitis?
Another 5 seconds.
Okay, good. So again, most of you have got the correct answer. Well done, which is B. Some of you put obesity, some of you put menopause. That's absolutely fine. Okay, so we did mention about this being a very common, well, not very common, but an important risk factor, an important cause of acute pancreatitis. Now, the key with this sort of spiel is we weren't ever told that she had an ERCP. There was kind of two stages to the question. The first thing, we needed to work that out, okay? And the clue there is that she says that she had a stricture of her bile duct that needed investigation or management. And the only procedure, especially the ones out of this, that would be used for that is an ERCP. Okay, so you needed to kind of deduce that first. And then the second thing was to work out, well, actually, she's had that now. So that is actually a big risk factor. We're not told that she's an alcoholic. We're not told that she has any gallstones, and they're not actually part of the answer either. So out of all of these, the sort of main one that we're looking at is that B. Okay, so obesity. I mean, obesity on its own wouldn't necessarily be a direct risk factor. It may be linked to acute appendicitis from other ways, things like diet, and increased risk of gallstone because you're obese, that kind of stuff, and likewise with menopause. But it doesn't necessarily have a direct impact. And when we've got something else there that's a sort of a lot more relevant, then we can kind of confidently say that it's more likely to be B over C. Okay, so well done everyone who got that right. Right. So just to kind of sum up the management, so fluid resus is really important, and basically A2E approach first of all when they're unwell, because they will be unwell. All right, so don't forget approaching anyone who's unwell, A to E assessment. Within the A to E assessment, you want to make sure that you've got things like fluid resuscitation sorted, analgesia, really, really important and often missed by juniors because we sort of go straight in a bit too high and we forget the basics. The basics have to be addressed first. Make the patient comfortable. Give them an antiemetic as well, because they're vomiting. Vomiting is going to be making the pain a lot worse because they're going to be constantly moving as well. So try and calm them down, try and make them comfortable. Okay. Once you've done all of that, that initial management, you then need to think about potentially doing an ERCP to get rid of those gallstones if that's the cause. And remember, that is the most common cause at the moment. If it's not that and it's down to alcohol, we need to think about alcohol detoxification. And that's key not only in the acute setting, but also to prevent further episodes of acute pancreatitis. It's important to consider nutritional support because these patients might be unwell for a while. They may not be getting their nutrition correctly. So we sort of need to make sure that they are able to have that energy to heal. Otherwise, they won't recover as quick as possible. Correcting electrolyte abnormality, that is common, again, in any unwell conditions, but more so with acute pancreatitis. So we need to make sure we look at that, particularly things like calcium, magnesium phosphate, as well as the sort of normal electrolytes. If there is an infective cause and you can be dictated from the white cells, the CRP, that kind of stuff, then antibiotics are indicated. If it's not, it's definitely not an infective cause, then it's not always kind of the priority to start antibiotics. Okay, so I think from a exam question, it could be any of these, but from an actual realistic point of view for being a junior, we're going to be really, really keen on sorting that out first, or all of these kind of other things, and then looking at the further management. Okay, so interestingly, surgery is not on there, even though this is, or it could be a surgical kind of lecture, but it's not on there because we normally don't do surgery for a lot of things in the acute inflammation stages. Right, so it might be something later on, particularly if it's a cancer causing or maybe a gallstone or difficult gallstone causing. But in the acute setting, we need to just calm things down first and address the actual kind of acute issue. So we talked about this being a really nasty disease, and it does have a sort of, it is a significant problem with complications. Okay, so in severe cases, there is a 30% mortality rate. That's significant, okay, considering that it's such an acute thing, or acute presentation. Prognosis varies a lot depending on, well, what actually caused it. So gallstones, if it's caught early and treated well, has a reasonably good long-term prognosis, but unfortunately, alcoholic causes has a very poor prognosis because of the alcoholism in general, associated with liver disease or whatever else. Mild disease, which we already kind of talked about, is relatively rare, especially in an emergency department presentation. But if it is mild, often with conservative management, so things like fluids and the painkillers and things like that we talked about, leads to about an 80% survival, as long as we have controlled that mild disease and not let it get a lot worse. Okay. However, if there's going to be any complications, which there are, the main things people can get is renal failure. So firstly, you can get acute kidney injury and then prolonged into kind of chronic renal failure. You can get things like pancreatic abscesses and pseudocyst. So pseudocyst is a collection of fluid which is not always infective. Pancreatic abscess is usually more infective in nature. And that can be really difficult to diagnose and therefore also treat. Sepsis is always going to be a complication of anything that's associated with an infection, particularly if it's gallstones caused as well. fistulas as well, so you can get fistulas developing around that whole area. And then chronic pancreatitis is that main one. So people who have sort of recurrent bouts of acute pancreatitis may fall in the category of chronic pancreatitis, which we'll be talking about later. Okay. Right. So question 6. 48-year-old alcoholic admitted to hospital for a distal pancreatectomy. So this is an elective procedure or a semi-elective procedure because of his chronic pancreatitis. He's high risk of developing alcoholic withdrawal seizures because he's a known alcoholic, and he usually drinks 500 mils of vodka every day, which is a really significant amount. So what appropriate medication do we give him to prevent that from happening? We'll put the polls up, and again, please just guess if you don't know.
Another 5 seconds.
Okay, good. So the answer was C. So we still got the majority of people have put that. However, quite a few of you have put lorazepam. All right. Now we'll go through this in a bit, because you might be thinking, oh, well, this is alcohol withdrawal. This is not chronic pancreatitis or whatever. But it's really important that this is actually part of the management of chronic pancreatitis, because it's very, very commonly associated with it, as we'll talk about later. All right. So the key with this question is reading what they want us to do, because the people that put A, they are kind of correct in the sense that lorazepam is used in withdrawal seizures. Okay. However, the question says appropriate medication to prevent this from happening. So prophylaxis of withdrawal seizures, okay, rather than treatment or management of withdrawal seizures. So for that, the correct answer is chlordiazepoxide. Okay, so lorazepam is used in the management. So once they have a seizure, we will give lorazepam, but there's not much of an indication to give it to prevent actually developing those seizures, and of which chlordiazepoxide, or Librium as the brand name is used kind of in most patients who you screen for alcoholism. All right. Methadone, I'm sure you all know, is more for IVDUs and opioid addicted people. Naloxone is used for the reversal of that, so opioid overdose, and heparin is kind of given to IVDUs sometimes to prevent them from getting clots, okay, and used for obviously other things as well. Okay, right, so now we're going to talk about chronic pancreatitis. So most of what we've already talked about with the acute kind of sticks with this, okay, but the difference is it's recurrent or persistent injury to the pancreas and surrounding structures. Okay, so it's not that it's an acute bout, it's not that it's you know, sort of any different to acute pancreatitis in terms of the pathology or anything like that. It's just that they'll get lots and lots and lots of bouts of acute pancreatitis that kind of form then chronic pancreatitis, or they have persistent injury that's either undertreated or just not able to treat. Okay, We can split this up into what we talked about. So recurrent acute pancreatitis, idiopathic pancreatitis, basically there's no sort of real or no known cause. So we don't really know what's going on. Chronic relapsing pancreatitis. So this is where they have a level of chronic injury with sort of relapses or episodes of acute sort of worsening injury to it as well. And then established chronic pancreatitis, where they've just got that kind of overall arching kind of permanent or persistent injury to the pancreas. Okay. Now, for chronic pancreatitis in the UK, this is the majority that is associated with alcoholism. All right. And the reason is because when you have that 25% of people who have acute pancreatitis, because it's caused by alcoholism, if they continue to drink, they will undoubtedly have further episodes of that acute pancreatitis, which would then lead to chronic pancreatitis. People who have gallstone associated acute pancreatitis wouldn't necessarily get that real sort of recurrent, repeated gallstones, particularly if we manage them and take the gallbladder out. Therefore, they tend to just stick to acute pancreatitis, and it's those 25% that sort of get through the net and then develop into chronic pancreatitis. All right, so more than 70%, pretty much most people who have chronic pancreatitis, you would associate it with chronic alcoholism. Okay. Right, so the way this presents, it is very similar. So you still would get abdominal pain radiating to the back, but this can just be kind of chronic in nature, so not as severe, or it can be, you know, sort of bouts of flare-ups, as we talked about before. Okay, but what they do tend to get is malnutrition, and that's sort of the big presentation of the big problem. They can also get steatorrhea, which is stools covered around fat. So you can get that with a variety of other diseases too. And they can also develop diabetes, because if you think about what diabetes is, it's all to do with insulin, which is produced by the pancreas. So if you have poor pancreas function, then you can develop the actual manifestation of diabetes because of that. All right. So obviously, in terms of complications, we've already got certain things, you know, that we know what the complication of malnutrition would be and diabetes would be. So that's something we need to sort of think about, really. Okay. So investigations, you would do pretty much most of the stuff that we've already done, and you'd get raised or very similarly raised blood markers. The amylase will be raised. You know, it might be still sky high, but chronically sky high, or it might be sort of raised, you know, kind of medium raised. So yeah, often we find blood glucose is raised again because of that diabetes, the suppressed insulin. And this one, really, we should do a CT or an ultrasound, basically just to have a look at the extent of chronic damage to the pancreas actual organ. Okay, so in that way we might see things like calcifications, actual enlargement, maybe even dilatation of the ducts itself. Right, so now we've got a 60-year-old woman. So she's got known chronic pancreatitis, secondary celiac disease. Now that's quite a rare cause, but nevertheless, it's happened. And she's discussing options for surgery as her ALP is persistently raised. Okay, so which one of the following is a known method of surgery used for biliary decompression? Now this is quite a hard question. So again, please just guess or make a kind of informed guess if you can.
Another 5 seconds.
Okay, so a bit of variation here. I expected that because, like I said, it's a hard question, but still, I'm quite impressed. The majority still got it correct. So it is this Roux-en-Y colleague. I can't even say it. So choledochondrogenoscopy. I'm not even going to try. Okay, so it's not really anything we need to go through. It's just essentially learning it, to be honest. Anterior resection is used for bowel or colorectal cancer, specifically rectal cancer. Nissen fundoplication is used in gastric surgery. The Foley operation is used in urology, and Hartmann's is also kind of gastro surgery as well. Okay, so there's nothing we can go through. It's just this is the method for biliary decompression. It's relatively rare, but it's the known kind of method. Okay, right. 65-year-old South Asian gentleman. He's diagnosed with chronic pancreatitis. He's never drunk alcohol because of religion. He's not smoked, but he does have significant medical problems. Now, which of the following conditions is associated with chronic pancreatitis, bearing in mind the kind of the sort of history for him? So hopefully this will be relatively easy.
Another 5 seconds.
Okay, good. Yep. So I think probably slightly easier. A big majority got the correct answer. I mean, again, there's nothing to really go through because it was mentioned in that first thing, but there is a big association with diabetes. He's got all the risk factor for diabetes as well, you know. So, sorry. We do sort of say, you know, we shouldn't prejudice or anything or assume people based on you know, whatever. But also in medicine, you do need to take into account ethnicity and risk factors, really, according to the stats. And a 65-year-old South Asian man is a big risk of diabetes. Okay, you know, so on his own, without the chronic pancreatitis, let alone along with the diabetes. Okay, so you can actually get both ways. So diabetes can cause chronic pancreatitis, and chronic pancreatitis can cause diabetes. They work in both ways. All right. So yeah, that's essentially the answer. Down syndrome. There's not really a known link between that. Asthma, again, not really a known link. Now IHD. He has got potentially risk factors for ischemic heart disease, but again, it's not associated to chronic pancreatitis. And gastric cancer, again, very, very, very loosely related to chronic pancreatitis. It's not the one that is the obvious choice here. Okay, good, right. Last question now. So 67, known alcoholic. We've got the diagnosis of chronic pancreatitis already. Abdo pain, right upper quadrant, worse than usual. He's got jaundice too, and LFTs show obstruction. CT scan shows a well circumscribed round collection of peripancreatic fluid surrounded by a well-defined enhancing wall. So what's the most likely diagnosis, or we could say what's the most likely complication of the chronic pancreatitis in this gentleman? Okay, so we'll put the polls up now.
Another 5 seconds.
Okay, yep, good. So most of you got, most of you got the correct answer. I don't know why the arrow's not coming up for that. Apologies for that, but it is pancreatic pseudocyst. Okay, so apologies, the arrow's not kind of come up. So most of you did get that right. Now, there are some links with some of the others in terms of complications. Pancreatic cancer is a loose kind of complication to chronic pancreatitis, and you probably would see that in a CT scan. Okay, however, if it was a tumor, it wouldn't show up as a collection of pancreatic fluid surrounded by a well-defined enhancing wall. So we've basically got that that sentence there is essentially, it gives you the diagnosis. So it's not that. It's not going to be gallstones as well, because gallstones aren't fluid. It's not going to be SBP, because even though SBP is fluid and it would show up as fluid on a CT scan, it's not you know, kind of a collection within a wall or a well-defined wall, and you also wouldn't see it within the pancreatic space, or the peripancreatic area. Hep B infection is just kind of put in there as a bit of a red herring, really. So Hep B infections can give liver abscesses, or really, really rare types of liver abscesses. But again, you know, we won't necessarily see that on the scan. So cysts, from anywhere, like abscesses, are basically fluid surrounded by a well-defined wall. So it's like a sac. You've got fluid in. The difference between a cyst and an abscess usually is that the cyst is non-infective. It could be inflammatory, but non-infective. Usually kind of clear serum fluid, rather than an abscess, which is collections of white cells and debris, or pus, basically, which are more likely to do with to be caused by an infection. All right, but both are collections of fluid with a surrounding wall, basically in a sac. Okay, so pancreatic pseudocyst is the answer, and it is a well-known, albeit relatively rare, complication of chronic pancreatitis. All right. So management of chronic pancreatitis. Now, this is, you know, going to be a lot more to do with community care. It's going to be a lot more to do with lifestyle management, which can be things like diet, but it's mainly going to be that alcoholic detoxification, getting someone to reduce their alcohol intake, or to cut it out completely over time, and hence stop a recurrence of acute pancreatitis or another flare up of the chronic pancreatitis. So it's really important that we push that. Now, there is a stage where no amount of alcoholic detoxification will really make a difference, because they're almost so far down that line. But it's still really important that we push that with patients, and we get them to actually realize the damage that they're causing. Okay. The other lifestyle managements, it could in theory be maybe kind of diet related, particularly with diabetes. So if they develop diabetes, then they are going to need to, worry about that side with diet and exercise and all that kind of stuff. Okay. Pancreatic enzyme supplements and nutritional support. So I'm not going to go into a huge amount of detail into that, but you may heard of tablets called like Creon, or some other type of tablets, which essentially just replace what the pancreas is not really able to produce itself. And likewise insulin. So if their diabetes is really bad, they may even need insulin to sort of replace it. Okay. Surgical management, I mean, there is a scope for it, but it's more when complications arise. So biliary decompression is used, when you've got a complication of obstruction, essentially. and you need to sort of get that kind of fluid or get that bile back into flow, really. And we've already talked about what procedures you use for that, which I'm not going to attempt to pronounce again. If anyone develops a pseudocyst, they do need that draining, because that will have a mass effect and make things a lot worse, and they can have further kind of complications with that. And distal pancreatectomy if you've got a really nasty chronic pancreatitis that is a risk of even becoming necrotic and then causing further kind of sepsis and further complications. Okay, so I think really there is scope for surgical management, but often, again, from a junior level, we need to be really focusing on this aspect and this sort of thing, because this is really something that needs to go hand in hand, or regardless of what the further management is, we need to be pushing these for all the patient, or especially the lifestyle management for all the patients. Okay. So we talked about a few of these already. So pancreatic insufficiency through basically just poor function. Diabetes mellitus, we've talked about. Obstruction caused by, just chronic damage, inflammation as well, obstruction of the bile flow. Pancreatic cancer, there is a risk, unfortunately, with chronic pancreatitis. Pseudocysts, we've talked about, and alcohol-related disease, basically everything else that alcoholism leads to, to liver disease and all that kind of stuff. Likely, unfortunately, that's going to kill them before anything else. So in terms of mortality, chronic pancreatitis might be reasonably protective, or might be reasonably treated, but unfortunately the actual alcoholism or the liver disease may sort of kill them first. Okay, so the overall prognosis is quite poor. Right, so that is it. So really quick sort of whistle stop of acute and chronic pancreatitis. I know we talked a bit more about acute pancreatitis in terms of the presentation and everything like that, and the only reason is because they sort of do have a lot of overlap in terms of kind of presentation and causes and things like that. So in terms of differentiating between the two, it's not something that we would expect to do all the time, because it just depends on the actual scenario, the context, who the patient is as well. Okay, any questions at all? I will see if there is anything in the chat. I might need to stop my screen share, Millie, if that's all right.
That's fine, or I can read them out for you if it's easier.
I can see them now. So should I go through the Q&A, or should I go on the chat box?
I think there's mostly questions on the Q&A. I don't think there's anything on the chat box, but I'll keep an eye on it.
Cool, that's fine. Right, so we've got a question. So why is it a pseudocyst and not just a cyst? Good question. That's a really good question. Now, the reason that it is usually because a cyst is actually kind of on its own. It's kind of an entity on its own. So usually what we would see is a cyst basically outside of organs or anything like that. A pseudocyst is kind of part of the pancreas. So even though it's a sac, the sac is the pancreatic wall. So it's kind of a fluid-filled collection within the pancreas itself. Hence why it's a pseudocyst and not just a cyst. Because if you think about, if you've got a cyst on your, on your skin or whatever, it's a self-contained sac that usually what happens is you drain it and then you take away the sac as well. But with a pseudocyst, you can only you can sort of only drain it first, and you can't really take the sac out, because that's the pancreas. That's the actual wall of the pancreas. Okay. So the next question we've got, what is the most common infective cause of acute pancreatitis, and which antibiotics are used? So good question. So this is basically, I mean, there's no sort of common or there's no sort of infective like bacteria or anything that tends to cause it straight away. So what we normally see is infections that are opportunistic. So usually you get an infection due to the gallstones. So when you have gallstones, you have a greater risk of infection because the flow of the bile is not there, essentially. So you can get things like usual E. coli and all of the gut bacteria, and you can also get things like the Pseudomonas and the anaerobes as well. So it's usually secondary to gallstones. I think it's very, very rare to get an infection that straight away causes acute pancreatitis without that sort of method. I'm not an expert on it, so you might find that there is some bug or some infection that sort of straight away causes acute pancreatitis. But as far as I know, it's usually from the gallstones itself, okay? So which type of diabetes is caused by pancreatitis, i.e. would it be considered type 1, type 2? Okay, good question. So it's usually type 2, because when you look at the difference between type 1 and type 2, you think of type 1 is complete lack of insulin, and type 2 is insulin resistance. So to an extent, it depends on the degree of damage to the pancreas. And it basically just follows that same system. So if there's complete lack of insulin production, which to my knowledge is very rare, it could be considered type 1, but in most scenarios, it's insulin resistance or kind of lack of insulin production or low levels of insulin causing resistance. So, you know, more likely to be that, okay? Do we check for amylase levels in chronic pancreatitis? Yes, I mean, we do check, but you will find that they're chronically raised. So what would be quite good, especially when you're looking at kind of acute flare-ups in a chronic pancreatitic patient, is you need to compare it to the last one, because you might find that, for example, their baseline is around 200, 300, and it's now shot up to 560 or whatever. Okay, so we do still check them, but maybe not isolated. We have to compare to their previous ones. Okay. Risk factors: did the 65-year-old non-smoker, non-drinker have for IHD? I mean, the main one is, again, it's a loose risk